Hello everyone, my name is Karol Hoang, and today I will be presenting on multiple sclerosis, one of the most common and devastating autoimmune disorders affecting young adults worldwide. MS is a chronic condition where the body's own immune system mistakenly attacks the central nervous system, specifically the brain, optic nerves, and spinal cord. The primary target is the myelin sheath, the fatty insulation that surrounds our neurons. When this myelin is damaged, nerve signals slow down or stop entirely, leading to a wide range of neurological symptoms. What is multiple sclerosis? Multiple sclerosis is a disease of the central nervous system where the immune system mistakenly identifies myelin as foreign and attacks it. This is a type 4 hypersensitivity reaction. There are four types of hypersensitivity reactions. Type 1 is, think about an immediate allergy, like a hive fever, or a peanut allergy. Type 2 involves antibodies attacking cell surfaces. Type 3 involves immune complexes, but type 4 is different. It is cell mediated, which means it is driven by T lymphocytes rather than antibodies. This is why MS is often called a T cell mediated disease, though we now know B cells also play a critical role. The clinical courses vary significantly between patients. About 85% experience relapsing remitting MS. These patients have acute attacks called relapses, where new symptoms or appear or existing symptoms worsen. These attacks last days to weeks, followed by periods of partial or complete recovery, called remissions. The remaining 10 to 15 have primary progressive MS. These patients experience steady neurological decline from the very beginning without distinct attacks and recovers Additionally, many patients with relapsing remitting MS eventually transition to secondary progressive MS, where the disease begins to worsen steadily regardless of relapses. Understanding these different disease courses is critical for treatment decisions. So the epidemiology. Who gets multiple sclerosis? MS is not a rare disease. Nearly 2.8 million people worldwide live with MS, including about 1 million Americans. Notice that women are 2 to 3 times more likely to develop MS than men. This suggests that hormonal influences or X chromosome related genes may play a role in immune regulation. The exact reason for this female predominance is still in active research. The typical age of diagnosis is between 20 and 40 years old, with the peak area around 30 to 35. Prevalence increases the further you live away from the equator, so places like Sweden, Canada, and Norway have the highest rate. This north-south gradient strongly implicates vitamin D, which is produced through sunlight exposure, as a protective factor. People in northern latitudes receive less sunlight, especially during winter months, leading to lower vitamin D levels, which may increase MS risk. So as we see here, this is the equator, and as we further move up near the north, so this is Canada, we have Sweden and Norway up here. As you can see, they're in red, which means they're way more likely to high risk of getting MS. Now, onto a brief history of MS. So here I have an image of Jane Martin Carcott, who fully describes what MS as a distinct disease in 1868. And in the middle here, I have an image of an MRI, the first MRI of a patient with MS in 1970. So according to a 1981 study in the Lancet journal by Ian Young and colleagues, the first MRI study of MS patients was published. They studied 10 MS patients and found that MRI detected 112 lesions. CT scans, standard imaging tool at the time, detected only 19. This is a massive difference. This was the first decisive clinical advantage of MRI over CT. It proved that MRI could see the hidden damage in MS that other tools missed. The silent lesions that were causing damage even when patients weren't experiencing symptoms. This finding led to massive investments in MRI technology. That same year, the first commercial whole body MRI system was installed at Hammersmith Hospital in London. Today, MRI is the gold standard for diagnosing and monitoring MS. Finally, in 1993, the first disease-modifying therapy, interferon beta 1b, was approved by the FDA. This was the beginning of the treatment revolution. So, what triggers MS? What actually triggers the immune system to turn against its own myelin? MS is not caused by a single factor, rather, it is a complex interaction between genetic susceptibility and environmental triggers. The strongest genetic risk factor by far is a variant in the HLA system called HLA-DRB1 1501. This gene variant increases risk about threefold, but genetics alone cannot explain MS. Many people with this gene never develop the disease. The most compelling environment trigger is Epstein-Barr virus infection. The same study found that EBV infection increases MS risk by 32-fold, which is crazy thinking that now we understand that there's some correlation. So the leading or hypothesis to this is called molecular mimicry, where the idea that certain protein on the EBV virus look structurally similar to myelin proteins. When the immune system generates T cells to fight EBV, some of those T cells accidentally recognize myelin as their target because of their structural similarity. This leads to an autoimmune attack, vitamin D, and so that's one way, but the other environmental factors are vitamin D deficiency, smoking, and obesity during adolescence are additional factors that likely interact with genetic susceptibility. Moving on to cytokines. So cytokines are the chemical messengers of the immune system. Looking at the left column, pro-inflammatory cytokines are overexpressed across the board. Interferon gamma activity activates macrophages and microglia. TNF is directly toxic to oligodendrocytes. It kills the very cell that produces myelin, and IL-17 produced by Th17 cells disrupts the blood-brain barrier, and IL-6 promotes the differentiation of pathogenic Th17 cells while simultaneously inhibiting regulatory T cells. Now looking to the right here, we have the anti-inflammatory deficiency. So these anti-inflammatory cytokines that normally put the brakes on immune responses are relatively deficient. IL-10 normally suppresses inflammation and promotes resolution of immune responses. TGF-beta normally promotes the development of regulatory T cells. This imbalance to too much pro-inflammation and too little anti-inflammation explains why inflammation in MS is persistent and why spontaneous remission is often persistent. Now, moving on to the system. So I have an image here explaining the most common symptoms, and I'm going to go into it. So the most common here at the bottom, as we see, is optic neuritis, which means inflammation of the optic nerve. And it's one of the most common persisting symptoms. Patients experience painful vision loss, often in one eye, sometimes described as looking through a smudged window. Motor symptoms include weakness, typically affecting one side of the body or both legs, along with spasticity, stiffness that interferes with smooth movement. Sensory symptoms are extremely common. Many patients describe numbness, tingling, or a sensation of electrical shocks traveling down the spine when they bind their neck forward. Coordination problems occur when the cerebellum is involved. Patients may develop tremor, lose their balance, or have slurred speech. Bladder dysfunction, um, at some point, either urgency, frequency, or difficulty emptying the bladder. But the most disabling symptom for many patients is fatigue. Up to 90% of individuals with MS experience significant fatigue, not just feeling tired, but a profound exhaustion that interferes with daily activities. Heat sensitivity is also characteristic. Even a small like increase in body temperature from exercise or hot shower or warm weather can temporarily worsen symptoms. Now on to the diagnosis. How do we identify MS? So diagnosing MS is not straightforward. In 2026, there's no single test that definitively diagnoses MS. Instead, neurologists use the McDonald criteria, which require demonstrating two things. First, is the this dissemination um, in space, meaning lesions must be present in at least two characteristic locations in the central nervous system. These locations include the periventricular region, the juxtacortical region, the infra infraterritorial region, including the brainstem and cerebellum, and the spinal cord. And second, we have what they need is dissemination in time, meaning lesions must have occurred at different times. This can be shown by having at least two distinct clinical attacks or by finding a new lesion on follow-up MRI compared to an earlier scan. MRI is the gold standard diagnostic tool. The most characteristic finding is called Dawson's fingers. These are ovoid or finger-like hypersensitivity that radiate from the ventricles of the brain. They have high hypersensitivity for MS. Cerebral spinal fluid analysis provides supportive evidence, and oligo- oligonal oligocanal bands, antibodies produced by B cells within the central nervous system, are present in over 95% of MS patients. And now, onto the last slide, or second to last. Um, the current research and future directions. So, despite the progress in treating MS, we still have a long way to go. It remains incurable, but research is moving forward, luckily, on multiple exciting frontiers. So, first, the gut-brain axis. According to a 2025 article in the Journal of Translational Autoimmunity, the gut microbiomes of MS patients differ significantly from patient healthy controls. They have reduced levels of like bacteria that produce short-chain fatty acids, uh, compounds that are crucial for regulating inflammation. This fibrosis may increase intestinal permeability, allowing inflammatory signals to enter the bloodstream, which then affects the blood-brain barrier. This is a completely new way of thinking about MS. That what happens in your gut might influence what happens in your brain. Second, remyelination therapies rather than just suppressing the immune system. These drugs aim to promote repair by recruiting oligodendrocytes, precursor cells to generate new myelin. Drugs like clomestine, an old antihistamine, have shown modest evidence of proof of concept studies. So third, EBV vaccination. If the Epstein-Barr virus truly is crucial trigger for MS, then developing a vaccine against EBV could potentially prevent MS altogether. Several research groups are working on this though challenges remain. Finally, biomarkers, serum um, neurofilament light chain, protein released when axons are damaged, correlates with relapse activity and predicts future disability. This could allow doctors to monitor disease activity with a simple blood test. And here are my references. Thank you.